I'll take this opportunity to invite our first speaker, Dr. Chitra Ramamurthy. As we all know, she is one of the most dynamic ARC Academic and Research Committee Chairman of All India Ophthalmic Society at present, and she is doing some amazing webinars and amazing work as ARC Chairman, which was never seen earlier. Very warm welcome to you, Dr. Chitra Ramamurthy. And she is also the director of the Eye Foundation, chairman of Eye Foundation in Coimbatore. She will be talking on update on IOL power calculation. Dr. Chitra Ramamurthy, please.
Can you see my screen now?
Yes, ma'am.
So let's start off with the first routine talk before we go on to more challenging ones. So essentially, why we need to have a greater insight into IOL power calculations is because of the increasing expertise of the surgeons, yes, but also because of the increasing desire of our patients to get target immertropic outcomes. It's not going to the next, yeah. So if we try to trace the history, it goes right back to the times of Harold Ridley, who discovered the first intraocular lens in 1940s, and in his lifetime in 1980 underwent a further modification of this lens during his cataract surgery. But today, where we stand, we are able to realize a target immertropic outcome within plus minus 0.5 diopter for most of our normal patients, may be challenged in extremes of axial length and post-refractive surgery. So it automatically tells us that we need to do a very careful biometry and choose the right formulae. If you try to understand what are the existing biometers which are popular now, yes, we still do have immersion A-scan and the different optical biometers today, but there is some difference which is there, which is not very overpowering, of course. Like if you look at the ultrasound, it works at the frequency of 10 megahertz as against an IOL master, which works the frequency of 780 nanometers. In other words, definitely it goes without saying that there is a greater penetrance and greater accuracy and that fixation check, which makes it even more accurate. But having said that, the ultrasound also does detect in a good range, maybe a little variable between the two would be about 200 nanometers. If you look at the immersion biometry, what is most important for us to see is that the spikes of the cornea, the anterior and the posterior lens, the retina and sclera should be of nearly equal amplitude, and the standard deviations amongst these a few readings should not be more than 0.06. We should not compress the eye, and we should keep our gain lowest at which you get these amplitudes. As far as the optical biometers are concerned, we have different ones at slightly varying principles, but all getting the most optimal end result. If we talk of the latest of ones is the IOL Master 700, which has incorporated the swept source OCT, combined it with the B-scan biometry, wherein it measures also the corneal thickness and the lens thickness, and again has that phenomenal fixation check and the 3-zone telecentric cataract. So what are the sources of error? The one major error is our difficulty in estimating the effective lens position, and commensurately the post-op refraction gets challenged and the axial length measure. This constitutes about 79% of the error, and the corneal contribution is about 21%, because we need to have not just a comprehensive measurement in normal corneas, but we need to get the final answer in abnormal corneas and corneas that are modified surgically. We, of course, have a conglomerate of technologies, but they all measure at different points, like manual K at 3.2 millimeter ring. The IOL Master has 3 rings with 18 spots, and the Lens Star has 2 double rings. So essentially, even manual keratometry is fairly okay, because it also gives us a measure of the magnitude of astigmatism and axis. But what is this new thing about the total keratometry which is being talked about? Essentially, what it does is it uses a toric model and measures on the anterior corneal surface, and with the help of the swept source OCT measures the corneal thickness and interpolates the posterior corneal thickness values and gives an estimate of the total keratometry. Now, this can be incorporated in the Barrett's Universal 2 and gets called as Barrett TK Universal, in Barrett Toric, and gets called as Barrett TK Toric, and more. But then, if this total keratometry gets incorporated in the other formulas, we need to remember The other formulas have also derived some kind of a mathematical calculation to estimate the posterior corneal astigmatism. And we should beware that if we do this, we might end up overcorrecting it. And what is this? I talked about telecentric keratometry. It is the ability to maintain your constant spot distance, irrespective of whether the chin is on the exact position or the headrest, in the exact headrest. In other words, it's a distant independent keratometry. So the preoperative workup is critical. So we've understood that the biometry is critical, but also the need to stabilize the ocular surface is so important. Now, if you look at this example, the left eye is showing an astigmatism of 2.67, where the right is showing 0.5. And we looked more deeply, we found that the patient had severe dry eyes, and following medications, the astigmatism dropped to 0.2 in both eyes. So that tells us how important it is to have the right measure. Now, this was again another patient who came for a cataract surgery, but you need to do a closer look. And we found that the K values in the right eye was flatter compared to that of the left eye. And then the patient comes out with a history that they had done LASIK 30 years back. So then you need to immediately change the mode and the formulae for laser vision correction in the right eye. So these become important. It also becomes important to verify the quality of raw data, like if the astigmatism is more in one eye, is it some abnormal topography you're looking, is the axial length measure more, or is it invariance or asymmetric in both eyes? We also need to understand there has been a generation gap in our understanding the IOL formulae. Like earlier, we started off with the theoretical formulae, and then came the Vergence, and today we have the Gaussian formula, and we have further gone on to more statistical ways of understanding. Like with the Vergence, the advantage was that we started incorporating 2 variables, 3 variables, and 7 variables in measurements in the very process of trying to get more precise on the effective lens position, which was the major challenge in the understanding or the evolving a better accurate IOL formula. Then came the artificial intelligence Hill RBF, which was essentially a very robust statistical model, which kept evolving so that the predictive error became even less in it. And of course, the ray tracing. So the next valid question is, how are the newer formulas different from each other? The essence is that each of them are trying to get best in measuring the effective lens position, because if the lens is little anteriorly placed, it needs a lower power. And if the lens sits a little posterior placed in the capsular bag, it needs a higher power. In other words, it is such a major challenge, and we have to be continuously running after improving our ability to measure this position of the intraocular lens in the capsular bag to get that final target emmetropia. So then, is it bad to use older formulas? No, it isn't. We do, but experience understand the value of these formulas in normal eyes. But let's even look at the Warren Hill database. Like earlier, when they had lesser data, there was 78% of them within plus minus 0.5. But today, with more and more post-operative results being incorporated in the database, there are more than 90% who are within 0.5 plus minus 0.5 achievable target. We even did a study comparing the 3rd generation formula against the 4th generation Barrett's, and you can clearly see that in long eyes, normal eyes, and short eyes, Barrett comes with a greater accuracy over 90% in within plus minus 0.5 diopters. So then, does it mean that we keep plugging our numbers into multiple formulae and compare the results? No, that's optional. Maybe you could try it once to understand with a number of eyes which formula is best suited for an eye. But would we ever have one formula that works for all? No, it doesn't. Because if you look at the dimension matrix of the human eye, what you see is that normal anterior chamber depth and normal axial length is seen in 73.4% of the eyes, whereas a normal ACD with a shorter axial length is seen in 6.9, smaller ACD with smaller axial length is seen in 1.8%, and a normal anterior chamber depth with a longer axial length is seen in 35.5%. So in other words, we need to evolve newer formulas, especially when you're dealing with extremes of axial length. The further advantage of Barrett Universal 2 is it is able to account for the principal plane in different geometry of lenses, like a minus lens or a plus lens, besides the fact that it has all these variables which is getting incorporated, which gives you a greater and a better estimation of the effective lens position. Taking you further on, now, as I said, all that I've said, like this is where you incorporate the name, the A constant, and the personalized constant, and all these essential measurements, and the lens thickness and the white to white become the optional measurements.
Ma'am,
You look at the
1
Hill
minute remaining.
RPF, what we realize is they have optimized now to an extended beta version, which gives precision even up to -5 diopters.
Ma'am,
So
you
what
have
is
1
the
minute
best
remaining.
way to deal with short eyes? Like in short eyes, you know that there could be a normal anterior chamber depth or a shallow anterior chamber depth. And because these are high-powered IOLs, you could have a larger refractive surprise. So you could use a customized IOL or a piggyback IOL in these eyes to add up to the lens placed in the bag. And in the challenge with the long eyes is the presence of cephaloma, which are better measured with the optical biometers. With the post-refractive surgery eyes, we have different solutions. Essentially, it is because the ratio between the anterior and the posterior cornea is altered. So we have the total keratometry, we have the pentacam EKR or the Galilees. So, but then you could use either the ASCRS calculator, which would give you the pre-op data and the no prior data, and then helps you allow you to measure. You could use the OCT formulas, which have come forward. You could use the myopic classic formula, wherein you need to use the least minus with which, because keeping in mind that we tend to underestimate the key and we could overestimate the IOL part. Now, this would be vice versa in the hyperopic eye. And these are the different formulas which could be used, and Barrett True-K definitely stands strong as far as this is concerned. And you could even get access to this in the apsrs.com or the ASCRS website. Radial keratotomy again has its own challenges and the difficulty in estimating ELP. So the challenge is how close to the center of the cornea can you get? And today with the ARCRS calculator, we do have the post-RK values to be measured too. Essentially with RK, of course, we need to be cognizant that there's going to be a challenge in the stability of the refraction in the first 2-3 months because of the transient hyperopia, which is there. Again, toric calculators have the Alcon calculator, which has the Barrett's algorithm incorporated. It has also the Barrett toric calculator, which can be accessed online. Even if you have the immersion biometer values, you could just add on the acoustic constant of the IOL power, which you're going to use, and it would give you the axis and magnitude. Essentially, whether you use the immersion or the optical biometers, you could still avail the newer formulas and get the best. So what is most necessary is that we keep on validating our measurements. That is, we as a surgeon, we don't remove ourselves from the process, but be along with our optometrists to know what is best we could offer for these patients. And most importantly, we need to stay informed because there is continuous process of evolution and latest developments are occurring, and we need to continuously improve ourselves and get best out of our own selves. Thank you very much.